finish, I just have the recorded presentation from Casey. I think you've come at the right time to.
And I'm honored to be here today to share with you a little bit of my work in environmental sustainability in medical systems. So today I'm going to talk about eye care service delivery, but particularly carbon footprinting within that realm. But before I branch into carbon footprinting, I wanted to first have you think about systems in general. So systems thinking, I always start with this with my students. It's really important when you're trying to solve large problems like greenhouse gas emissions. Outside of just the greenhouse gas emissions, hospital care is usually part of a pretty complex system. So I would typically ask, if I were there, I would actually ask you to raise your hands and tell me, what's required to perform a cataract surgery? What kinds of things do we need? Gave you a brief moment to think about it, but because I'm not there, I'm going to give you the answers that I could see while I was observing cataract surgeries. So the first thing is really trained professionals. You need to have people who know what they're doing to safely perform these procedures. They need to have a space to perform those procedures. That can be very different across the world, but usually it's a physical building that has some form of air conditioning or heating, ventilation, and certainly electricity. So all these things are needed. You need supplies, both reusable and disposable, and those supplies have to be manufactured. These are manufacturing of reusable instruments. Those reusable instruments, after they're used, have to be sterilized. That is its own process, which needs trained professionals and a system in place to maintain safety. The disposable supplies are also manufactured. There's a lot of those every day moving through the world. They have to be sterilized and then brought into various operating theaters. Once those items are used, they have to be disposed. So this could mean incineration. This could mean landfilling. This is a landfill in the central United States where a lot of our medical waste goes. And of course you need the patient. Can't really perform the surgery without someone on whom to perform it. So this is also a crucial element. And to get the patient there, they have to be transported along with all those other goods and the removal of waste. So there's a lot of transportation in this system. I wanted to start out with that systems thinking because that's usually the core of how we calculate carbon emissions. You have to understand the whole system. And carbon emissions are really this one metric by which we can measure environmental sustainability. So the way we do this is to use a tool called Lifecycle Assessment. It basically quantifies the environmental emissions of a product or process. So it starts out looking at raw material extraction, transportation to a manufacturing facility where those products are produced or the electricity is generated, those things further transported to the hospital where we might reuse some of the supplies, but ultimately we'll end up throwing out many of the supplies. And so this is what would be considered a life cycle of a product, or in this case, many products. And life cycle assessment says, okay, there's inputs at every one of these stages. We need materials, we need energy, and there's outputs. There's waste that's generated, and then there's emissions. So things like carbon emissions or greenhouse gases. Other air pollutants are generated at each step in this process. There's water pollutants and potentially even heavy metals that end up in the soil. And life cycle assessment sums up all of those different emissions into a single number, like a carbon footprint. And so that's how we calculate out these environmental emissions. And it's useful for us because, one, we can identify where there's hotspots in a system, right? Which elements of this system seem to have the largest proportion of emissions. And it also lets us compare different systems performing similarly. So one of the earlier papers is a carbon footprint of cataract surgery based in the UK. And their findings show that over half of the carbon emissions came from the procurement of supplies. Now in the UK, a lot of those supplies are single-use and disposable. Based on my previous work looking at hysterectomy and other surgeries in the US, this was not surprising. Most of our emissions are coming from those single-use supplies. When I read this study, I wanted to know what emissions would look like in a place where they weren't using disposable supplies in the same way that they tend to in the UK or the US, and that took me to our Eye Care system. so you've heard from Dr. Venkatesh, and I believe you'll hear from him again afterwards. I worked with Dr. Venkatesh in 2014 and 2015 as a Fulbright Fellow and looked at their process of care delivery and estimated the carbon emissions. And these were some of the results. So you'll see that the procurement of medical equipment is still a relatively large proportion of ARVN's emissions, but ARVN's emissions per phacoemulsification are far lower than the phacoemulsification emissions in the UK. This would be the equivalent of driving a car about 500 kilometers versus 25 kilometers is the same quantity of emissions. So big difference in the way that care is provided in terms of the emissions. But what was nice about working with ARVN is that they already have published peer-reviewed literature on their outcomes. So we know that for things like endophthalmitis, ARVN is performing actually a little bit better than the UK and the US. And so we know that the process is effective. It delivers good care. And it has the benefit here, we see, of reducing this carbon footprint. So ultimately, it's reducing the impact on public health, in addition to performing very well for that individual patient. And this is where I really want to get you thinking about your systems, your care delivery systems, and how you might refine it, because anything that we can do to prevent some of these large public health issues will be very beneficial in the long run. We know that climate change is a big issue. There are certainly other issues. India has a lot of air quality and water quality issues, and medicine plays a part in that negative impact. But they can be part of the solution as well. So when you're thinking about designing efficient care, the very first step is to really think about what you want to accomplish and where you might have the biggest impact. So before I really talk about the clinical side, I want you to know that it's not just clinical care that has these emissions. That's one factor, and it's certainly a large factor. But you may also think about non-clinical aspects. So in this case, the hospitals that I work with, they think about their food chain, right? They're feeding a lot of people, so they will often try to find healthier food, maybe local or organic foods, things that promote health. They look at energy reduction initiatives that have nothing to do with the clinical space, and also greening their hospitals. This is a green roof, and you can see some gardens. Those types of things have actually been found to help in healing. Now, if you're all in ophthalmology, that might not be as big of an issue. It depends on what kind of facility you're operating in. But it's just to think about the larger options available. It's not all clinical issues. This is everything in that large healthcare system. You might think solely about the facilities or the utilities. Can you switch to solar hot water or just solar panels in general? Or you might think about the process and the supplies, more the operations end of things, and this movement of materials through that space. And once you've kind of come up with some ideas on that front, you should actually go out and look at the literature, go see what's out there. And beyond literature, you might have some really good solutions right in-house. Right? You're working with a lot of different people. And every one of those people is an expert at the thing that they do. And they'll know if something is inefficient or not effective. And so it's really important to build up this interdisciplinary body that looks at these kinds of improvements. So it might be people who are working in infection control or some sort of compliance regulatory agency. You definitely work with your clinicians, that's nurses and physicians, mid-level ophthalmic professionals, everyone who's involved in the clinical care. It might be your pharmacy, your supply chain, waste management, building services, right? Who's handling this waste on the downstream, but getting them all together at the table. I'm an engineer, so a lot of the solutions that I come up with are only as good as the people I'm working with, right? I can point out the problems, but pointing to the solutions really requires a big team to understand how that solution is going to affect the whole system. So listen to your colleagues and peers. They may have very excellent ideas. There are other resources out there. This is the International Agency for Prevention of Blindness Environmental Sustainability Working Group. We're putting together documents and other kinds of resources for IAPB members. There's also the Royal College of Ophthalmology has a similar work group, and there's a lot of resources specific to eye health. You can do a lot of reading. There's a lot of literature out there that can be papers in peer-reviewed journals. It can be books. it can be just reports. So Global Green and Healthy Hospitals has a great network online, a good forum that you can actually go to and ask questions. It's beyond iHealth, it's a much broader healthcare resource. And the Center for Sustainable Healthcare down there in the corner has a forum specifically for eye care. So you can go to their website and actually join their forum and listen into the conversations about greening ophthalmology. So I just wanted to share a little bit about what Aravind is doing to maybe inspire some ideas for your teams if you're looking at greening your clinical service delivery. So Aravind, of course, has excellent outcomes. Their rates of endophthalmitis have actually gone down since they switched their antibiotic scheme. I'll let Dr. Venkatesh explain that side. But they're designed around efficiency. So you can see in this picture there's 2 beds per 1 surgeon. That is one strategy for increasing throughput, that the physician can go between tables, so one's being operated on while the other's being prepped, and the physician can just move back and forth between those 2. So designing your physical space can actually increase efficiency to get more people through that space more effectively. And also managing the flow of supplies through that physical layout is important. So that's one important strategy to think about. There's physical constraints, certainly you might not be able to rebuild, but with the space that you have, design it in a way that things can flow through the system more easily. Task shifting is another big one, right? So Aravind employs these mid-level ophthalmic professionals in order to reduce the tasks that the surgeon has to do that aren't related to the actual surgery. So the surgeon's only doing cut to close, and these mid-level ophthalmic professionals are the ones guiding the patient in and out of the room and taking care of the supplies and those kinds of things. And that's important in order to optimize the timing of every professional that you have working for you. Standardization is another really big one. In the US, we're pretty terrible at this. Every ophthalmologist does their own thing. We might have standard sets of supplies, but that doesn't guarantee that they're all being used all of the time. And so standardization across your surgical teams and across your hospital can be really effective and a really effective way to save money and to actually reduce your carbon emissions as well. Then you're looking at efficiency, right? So reducing your waste, maximizing reuse. At Aravind, they're using multi-dose, multi-use drops. In the US, we struggle particularly with the eye drops portion of this. We're required by law to have them single use, which leads to a lot of wasted drugs. It's very unfortunate. But finding ways to reduce that waste will be also critical. And finally, most importantly, maintain your safety throughout this process. If you have an adverse outcome, that leads to a much larger carbon footprint on the whole. So do it right the first time is basically the idea. And that's a really big element of it. And so, once you have kind of some of these strategies in place for yourself, you really have to start changing. And the way to do that, really energize your team, get everyone on board who needs to be on board, get them excited, start observing what's happening, start recording it, measuring it. You need the data to be able to show that things are changing in the way that you want them to change, and to also look out for any things that are changing in ways you don't want them to change, right? This is a complex system, so you have to be aware of all of those things. And keep reporting that. Find the barriers, right? What's causing issues? And keep asking why until you figure out really what's causing that issue. So that's important with any changes that you're trying to implement. And one thing that I'd advocate for as well, particularly when you're looking at supplies and things, is to look at the total cost, right? So don't just look at the purchasing price. You should at least think of the total cost of ownership. So thinking about what's it going to cost for you to dispose of these things, what are the other costs for acquiring those items, and if it's possible to look more at the societal impact. So what are the external costs of the things that you're doing? So easy approaches. One, monitoring your waste. So you can reformulate your preference cards or custom packs if you have those kind of prepackaged supplies, and communicating with your team about not wanting to open supplies into new. That's particularly important for the physicians. Work with your whole department to standardize your approaches. Work together to improve patient throughput. Partner with people in your supply chain, with other companies, to look into the total costs of reusable items, for example. And finally, partner with waste management to look for alternate disposal options. I think India is much better with recycling, but this is something in the US we really struggle with. Harder approaches, the asterisk is there because it might not be that hard for you. It depends on your position and what your system's already like. You might redesign your process, right? Develop some task shifting. Reduce preoperative testing or patient visits. That will cut down on the number of trips patients need to have. Could you do side-by-side operating rooms, if not dual beds? And what about simultaneous bilateral cataracts? That's just something I'm throwing out there. That's more of a clinical discussion that I think surgeons need to have, but it's an interesting one that could potentially reduce on some of these admissions. There's policy shifts. In the US, we're not allowed to send antibiotics home with patients from the operating room, so that's one. But I'm not sure what the policy shifts might be in India to encourage better reuse, but that's something to think about. And finally, pressuring your suppliers and manufacturers to offer better alternatives that allow you to reduce waste and emissions. That will take longer, but it is also important. So basically, don't forget about quality outcomes. Okay, if you're not achieving the best for your patient, you're not achieving the best for the planet. That's all I have for today. I think Dr. Venkatesh will be taking any questions that you might have for me. And please feel free to email me should you have any further questions. Thank you so much.